Okay, so so I'm going to talk to you guys about clavicle and scapular fractures in 28 minutes, which is probably not feasible. All right, so just some overall learning objectives that we'll go through is hopefully we'll be able to review just some relevant anatomy with regards to the scapula and the clavicle, go over very briefly some of the initial evaluation and management, and then really kind of talk about the non-operative and operative indications for both. Specifically for clavicle fractures, I do have a bunch of articles that are pulled, I think commonly, that people commonly cite. And then for the scapula, the one thing I wanted to go over was really just kind of the approach and some important neurovascular structures that can get in the way that occasionally will come up on your exams. Things I won't cover are AC joint, SC joint injuries, lateral medial clavicular fractures, and then isolated coracoid and acromial fractures. So for clavicle fractures, it's an S-shaped bone. It's the first bone to ossify, but it's actually also the last physis to close. So the medial clavicular physis closes around, early to late 20s. And so if you guys see adolescent patients with posterior SC joint injuries, that's sort of the reason why. On the lateral, as I talked about, the talk will mostly be focused on the middle third fractures, or fractures involving the middle, the mid-shaft region. On the lateral side, you have a bunch of soft tissue attachments of the AC joint, ligaments, and deltoid trapezius and pectoralis major. On the medial side, you have your SC joint, your sternocleidomastoid, sternohyoid, and also the sternal head of your pec major. And so because of these muscular and soft tissue attachments, that sort of also is another explanation as to why most of the clavicular fractures happen in the mid-shaft, because it generally is devoid of a lot of different soft tissues. So I was hoping to frame my talk around a case. So I think I wrote down some of the folks who are on the call, maybe. So Ellen. So this is a 24-year-old right-hand dominant guy who comes in, fell directly onto his left side while cycling, presents to the ER with left shoulder pain and a scalp laceration, but otherwise he's alert, oriented, Jesus at 15. Can you just quickly tell me what you see on the x-rays and things you'll be looking for?
Yeah, so this is an AP of the clavicle in a skeletally mature individual, and it looks like there's a mid-shaft fracture of the clavicle with some comminution. And some of the things I'm looking for are any signs of skin tenting. It actually looks like the x-ray on the right has a little bit more, like the bone is pushing up on the skin, but it doesn't look like it's open. Other things I'm looking for are the amount of displacement, and it looks like it's over 100% displaced. Yeah.
Okay. Would there be any other imaging that you'd want, that you'd need to help make, your assessment of some of the parameters you mentioned, so displacement, shortening? I don't know if you mentioned that, but that's another thing that you want to look for.
Yeah, I could also get a chest x-ray as well. Also to potentially CT to more have a better understanding of the fracture pattern, and then getting like shoulder views.
Yeah, so typically a CT scan is probably a little extreme unless it's really, really comminuted and you don't know, where all the pieces are. Then I think in that case, a CT scan can be helpful. But usually we would get bilateral clavicle views, which they can shoot on a single plate. And I think that's probably a more accurate way to really assess shortening. And then you can also, oftentimes these patients get x-rays in a supine position. So in this case, it's clearly displaced, but if you have patients that are maybe sort of on the border, getting upright x-rays, can also further show the maximal amount of displacement that the fracture will be at to, help with your counseling. In terms of skin tenting, maybe, let's see, Stephen, what specific things are you looking for when you're assessing for skin tenting?
Clinically, you're looking at the skin. I mean, the skin, you can obviously get a general appearance of what it looks like as opposed to the contralateral side, but then you're looking for blanching of the skin, feels like you can feel a sharp point that's like immediately threatening, or if it's already open.
Yeah, so that's very different than, someone who has a displaced fracture and it's just tenting, the underlying muscle, subcutaneous layers in the skin, in which case the skin over that deformity will be freely mobile. But if it's true skin tenting is exactly what Stephen said. So you have sort of a punctate, or not, it's not open, but you have sort of pinching of the skin. The discoloration is different, and it's really not that mobile. And so that's an important distinction, especially earlier on as you guys are seeing consults, to know sort of the difference between, skin lesions that are a little concerning, ones that aren't. And then of course, if you have any questions, just snap a photo or ask someone for help or to take a look. Okay. So clavicle fractures, are pretty common. As I mentioned, mid-shaft fractures account for up to 80% of the fractures that involve the clavicle. Generally, it occurs from a direct blow to the shoulder or a direct blow to the clavicle, such as a seatbelt strap. You can also have other associated injuries. So depending on their mechanism of injury, you also have to have a threshold to assess for other, injuries to the region as well. So let's see, maybe Erica. So what would you recommend for this patient? Let's say, you see him in clinic, it's non-dominant side, he's pretty healthy, he's active. What kinds of things would you talk to him about?
So I would say that you could probably treat this either operatively or non-operatively. And the choice is kind of his. Like, it's a displaced mid-shaft clavicle fracture, so he has about a 15% risk of non-union if he treats it non-operatively, versus operatively there'd be a 99% chance of union. But then just kind of talk about the risks associated with surgery and the risks associated with non-operative treatment besides non-union, including scar, numbness, hardware prominence, risk of wound infection, things like that. So I don't think I would push too strongly either direction, but since it is so displaced, maybe just tell him that he may have a slightly higher chance than 50% of non-unions, since it is even more displaced and comminuted than we usually see.
And how closely would you track him? Let's say, I don't know if I really want surgery. When would you have him come back?
Probably come back in 2 weeks, see how he's doing. And then again at 6 weeks, I guess, to see if there's progress towards healing. I forget the details, but anyway, I think it can be challenging because these can take a while to heal. So I think it's kind of hard to determine sometimes if it's just taking a long time to heal, but it's going to heal, versus if he perhaps is going on to non-union, but probably at 2 weeks and 6 weeks, and then depending on how he's doing, more closely or less closely after that.
Yeah, and I think that's really just to highlight that even if someone opts for non-operative management, it doesn't mean they come back to your clinic PRN. Similar to humeral shaft fractures and other things you manage in operative, you actually have to monitor them a little bit more closely, because what if the fracture displaces a little bit more? In this case, if he doesn't tolerate how he's healing, he'll probably self-present or maybe tell you sooner. So just making sure you actually keep a close eye on them, and then if you see them more often, then you can probably pull the trigger, and he'll probably tell you when he'll want surgery. So non-operative treatment. So historically, there have been a bunch of papers that have said, all clavicle fractures can be treated without surgery, which is why a lot of people just put them in a sling. So generally speaking, the indications are non-displaced or minimally displaced fractures without that much deformity. Sling immobilization anywhere from 2 to 6 weeks. That generally we advise that they limit overhead activities, because as soon as the arm or the shoulder comes to about 90 degrees of abduction, the clavicle actually sees a lot more rotational forces. So limiting that. And then there have been a lot of studies looking at just regular sling immobilization, and I don't even think we use them anymore, but figure of 8 braces. And the idea with the figure of 8 brace was they thought that it could help reduce some of the deformity, but all the trials have really shown that there's actually no difference in patient satisfaction, and comfort is actually better with the sling alone. So the figure of 8 brace generally has fallen out of favor. there was a recognition that, maybe not all clavicle fractures do that well. So this was one of the first studies that actually highlighted that 31% of patients that were treated non-operatively actually didn't have a good outcome, and the non-union rate was actually higher than what was previously reported. As Erica, was very keenly noted, they reported a 15% non-union rate, and they found that these unsatisfactory outcomes and non-unions were actually associated with shortening of greater than 2 centimeters. And when they looked at patients who actually had healed but in a malunited position, they also found that their outcome scores, so both constant shoulder score and also DASH, were lower than normal control subjects, and their strength was also weaker. So clavicular malunions, defined as, shortening of greater than 3 centimeters. And I bold shortening because I think shortening of the clavicle is perhaps underappreciated, in the sense that the clavicle and the scapula themselves work as a unit. And so if the clavicle itself is shortened, what happens to your scapula is everything sits sort of protracted and anteriorly tilted. And as a result, you can get scapular dyskinesia, and then that can also then impair your shoulder movement as well. A lot of patients come in complaining that they can't forward flex very high or abduct very far. Other things that can happen is, from a cosmetic standpoint, patients don't like the way they look. They have trouble, with straps and carrying a backpack if their shoulder is drooping. They can potentially also get things like thoracic outlet syndrome. So this study so this study looked at some risk factors for non-unions that also come up on your exam questions. So known risk factors for non-unions are being a woman, being older, and also fracture displacement and comminution. Smoking is also another one, but cited in a different study. This chart was actually interesting. I stumbled upon it when I was making this lecture. But essentially what they made, or they based this on, was a couple of different studies that have looked at non-unions, and the goal of this chart was to be able to counsel patients on where they fall in terms of their probability of getting a non-union, taking into account, fracture displacement and gender and also age. So for our patient, he would fall into the category of, because he's 24, a category of having an 18 to 20% non-union risk. So that was pretty interesting. I don't know that I'll apply that, but something to have maybe in your back pocket. So operative treatments, open fractures, impending open fractures, so skin tenting like we talked about, any associated vascular injuries, those are all, warrant thorough debridement and fixation. Relative indications that we kind of talked about, so 100% displaced with greater than 2 centimeters of shortening is an opportunity to talk to your patients about, risks and benefits, pros and cons of surgery and not doing surgery. Polytrauma patients is also a relative indications, and then the concept of floating shoulder, which hopefully we'll be able to touch on when we go on to talk about scapular fractures. So this is the landmark study that really kind of changed the practice of how we think about displaced midshaft clavicle fractures. So done by the Canadian Orthopedic Trauma Society, a randomized controlled trial of acute closed displaced fractures. And they found a significantly lower non-union rate in the ORIF group compared to the non-union group. So in their study, they reported a 3% non-union rate in the ORIF group compared to 14%. The non-union group also had a pretty significant symptomatic malunion that ultimately required treatment, and their outcome scores were also better over multiple time points. The time to union was also faster with fixation, so 16 weeks as opposed to 28 weeks. And then in terms of patients who had non-operative shoulder, or the non-operative treatment, again, from a cosmetic standpoint, they complained that their shoulder looked weird, or they had a bump, or it was asymmetric. But on the flip side, if someone had surgery, they had hardware irritation, incisional numbness, but overall, liked the way that the shoulder looked. Since then, there have been a bunch of other sort of RCTs and multiple randomized trials. I won't dwell on it, but surprisingly, they all found very similar results in that the non-union rate for the operative group is 1%. The non-union rate for the operative group is 1% versus 15% for the non-op group. So when you guys are counseling your patients, you see in trauma clinic or sports clinic or whatever, I think those are the numbers that you can use specifically, again, for displaced and shortened mid-shaft clavicle fractures.
And so I also had a question. When you're like looking at the AP and then sometimes like the oblique view, and all of a sudden, so like usually the AP doesn't look as displaced as compared to the oblique. And so are you typically using that for your measurements, or are you taking both into consideration?
Yeah, I usually take both. And the way that they actually, we talk about 100% displacement, but the way that the Canadian trauma group defined displacement was that there was no cortical apposition or no cortical touching. So I think I use that more in terms, as opposed to trying to like quantify how much is actually displaced. Is if the cortices, if the medial and lateral fragments are touching at all on any view, then I would consider that displaced.
Okay.
Yeah. So, but yes, you're right in that depending on the angle you shoot, that could fool you. So so having orthogonal views or multiple views can be helpful. And then again, also getting upright views, I think can be helpful as well.
Okay.
This is just the one that one study that's showing that smoking is also associated with non-union of clavicle fractures as well. Just for the sake of time, I'm just going to keep going. To address the thing about diversity, so there's a study that has looked at, does insurance status and socioeconomic status actually affect operative treatment of clavicle fractures? So this was an NIS or National Inpatient Sample Database study. Of course, it has all the weaknesses that come with database studies. But what they found is that patients were less likely to have surgery if they were uninsured, which kind of makes sense, Medicare or Medicaid, and then if they were a woman, Black, or Hispanic. And so, I think we see a pretty diverse patient population here, and like to think that when we counsel our patients, we're not considering those, but just know that, it's out there, unfortunately. Okay, so I can't see who's at Parnassus, but maybe Andrew. What surgical approach would you use and how would you fix this? Is Andrew there or someone? Someone who's a chief. I don't know that we can hear you.
Fagoni's in the OR as far as Parnassus goes, and I'm not a chief, but I'm happy to weigh in.
Sure. I don't know who you are. I can't see.
Oh, I'm Charlie. We haven't
okay, great.
Or we've met at anatomy.
Yeah, perfect. Okay, go ahead.
Yeah. So I mean, there's essentially two ways. I would treat this with a clavicle plate. And there's sort of two ways to put on the plate, whether you're doing it from an anterior. You can either plate anteriorly or superiorly. And lag screws and neutralization plate essentially would be the goal. You can also use locking plate fixation for these mid-shaft fractures. This is a comminuted fracture, but I do think you could probably still get a fairly appropriate anatomic read from the fragments, the main fragments that you do have. So I would probably, it's kind of dealer's choice, the anterior or superior plating, as far as I understand.
Okay. Do you know any benefits, pros and cons of either one?
Well, superior plating is probably a little bit easier to get access and to actually plate it, but you can have concerns more with prominent hardware, plating superiorly. You're also drilling right down towards a lot of structures like the lungs, which are not amenable to screw fixation.
What do you before you get to the lungs?
Well, you also have blood vessels, right? Like the subclavian vessels, but those also, I thought they were a little bit actually more posterior. So when you're going A to P, there's also a concern to hit those. I'd have to revisit my anatomy books, but I thought A to P was more concerned for the vessels, and superior to inferior was heading toward the lungs.
Yeah, so it also depends on where you're drilling, right? I mean, I think the idea is just know that there are scary structures there, and to not plunge, and also, use, Homans, benefits, whatever, to protect yourself or your assistant from plunging. But yeah, so generally speaking, so superior plating, some people think it's a little bit easier, it's a little bit faster. You just make an incision right over the clavicle. It's right there. It's less soft tissue dissection compared to the anterior plating. And yeah, so there's some thought that there's more risk to the surrounding neurovascular structures and lungs with superior plating. Anterior plating, you do have to take down some part of the anterior deltoid, and so some people don't really like that. One potential benefit of anterior plating is the more lateral or medial you have to go, your screws are actually longer, just because of the anatomy of the clavicle itself. And then some people talk about dual plating, so using like 227 plates, plating the front and the back, so that it's a little bit lower profile to reduce the risk of needing your hardware removed. So there's a bunch of biomechanical studies out there looking at plate fixation, anterior superior, anterior inferior. There's a bunch of stuff out there. But I think in my reading, the summary or the takeaways I got is that plate fixation in general is stronger than intramedullary nail fixation, which I really won't talk about because I don't have that much experience in. But what about anterior versus superior plating? And really it kind of just comes down to, what the fracture type is. So there have been studies that looked at if it's a transverse fracture, oblique fracture, comminuted fracture, fracture with inferior cortical comminution, the stiffness or the strength of the construct, superior or anterior, really kind of just varies and depends. So the literature is really kind of all over the place. But I think ultimately when you're applying it, there's really no clinical difference in healing rates and stuff like that between anterior and superior plating. This paper looked at, it was a cadaveric study looking at, how risky are the neurovascular structures in relation to anterior and superior plating. And even though they found in their study that there was no statistical difference between the distance of their screws between anterior superior plating, and in 6 of their specimens, or 35% of their specimens, the vessels were actually above the screws, and so, below, so caudal to the screws placed in the anterior plate. And so based on that, their paper essentially concluded that, anterior plating is maybe safer with regards to the neurovascular structures than superior plating. I mean, that's maybe a stretch, but something to consider. They also talked about how the subclavian vein is most at risk, and then after that is actually the brachial plexus. And they also quantified the at-risk zone. So that's 4 centimeters from the SC joint. So if you guys find yourself drilling or instrumenting anywhere close to the SC joint, it's just, again, raising your level of awareness and not trying to go too fast. And there are some things that you can do to help reduce the risk of injury and also increase the risk, the space between the clavicle and the neurovascular structures. And so you can add a bump underneath the shoulder itself, not necessarily the scapula, because the idea is you want the scapula to be protracted, so tilted more forward to put the neurovascular structures away. If you put a bump underneath the scapula, then you're retracting it and actually bringing the neurovascular structures closer. The other thing you can also do is put the arm in adduction, which also would bring the neurovascular structures further away from the clavicle. You'd mentioned, or someone had mentioned earlier, about hardware removal. This is a clinical study that they looked at anterior inferior plating versus superior plating, and they found that the anterior inferior group required less secondary procedures for hardware irritation than the superior group. It also resulted in additional costs. So that's something also to consider when you're talking to your patients about surgery. And so in their practice, they say that they have completely switched to anterior inferior plating for that purpose alone. But again, like you mentioned, I think it's sort of dealer's choice and depending on what you're comfortable with. So what we did for this patient, we did dual plating for that inferior comminution. So we did a long 2-4 plate to provisionally reduce our fracture, and then fixed it superiorly with a recon plate. Questions? That was unfortunately half an hour already. So I think this slide, if you guys don't remember anything from it, is essentially a summary of the mid-shaft clavicle fracture. So 1% non-union rate with fixate with ORIF, 15% non-union rate with non-op, faster time to union with surgery, better outcomes at most time points, improved shoulder appearance and strength. However, again, balanced with the risk of postoperative complications and the potential need for secondary procedures.